Well, I couldn't have had a more passionate and better introduction. Anna Louise, where is she? Thank you. I think I regard myself as a clinical phenomenologist, whatever that means. For the last 3 decades, I have worked as both a physician and a psychotherapist with people with physical illnesses. And all this work has been done in mainstream settings. And in this presentation, I'll focus on this experience. And I hope the experience will be of interest to you, whether your interest is the future of medicine or person-centred care or whole person-centred care, or research methods cognizant of the whole person, or evidence hierarchies and guidelines. Healthcare guidelines inevitably rest on assumptions about the nature of persons and the nature of disease. And since 1987, we've developed what we now call a whole person treatment approach to people with physical illnesses of many kinds. Naming what we do is both difficult and significant. I'm going to begin with a short story. A patient of mine, a high-functioning business consultant, in his late 40s, had endured severe sinusitis every year for 15 years. Those are the sinuses in normal anatomy. The symptoms always started in August and lasted until Christmas. And then he would recover, and then the next year it would all happen again. And I treated him. He had some house mite allergy, and the treatment for that did no good whatsoever. We then discovered that the sinusitis first began 15 years before, when his wife, on whom he was very dependent, gave birth to their first child. The child was born in August, and my patient had felt very competitive with the new baby son for his wife's attentions. I learned this both from him and independently in an interview with his wife, who had found his jealousy extremely problematic. You need to know that he'd been severely ill in early infancy, and throughout childhood he'd been coddled and protected by his mother. He then married a very proficient woman who took over his mother's protective role. Investigations and treatments, including sinus surgery over the 15 years of the condition, had failed to help. The sinusitis finally disappeared for good when together we noticed that each year in early August he would feel a dread coming on. The feeling, as he stated it, was, "It will be here again soon." Within 7 to 10 days he would be sick. Noticing this dread and then confronting it together over a few sessions actually resolved the problem permanently. In fact, that year, when we faced it, he didn't get it at all. In our whole person treatment approach, we attend to and integrate both normal medical elements and the patient's story, and I'll come back to that in a moment. It is not a question of either or. And we have clinicians doing this in various internal medicine disciplines: general practice, nursing, physiotherapy, dietetics, occupational therapy, sexual health, and psychotherapy and counselling. In the whole person approach, persons are not divided. We have a non-dualistic concept of personhood. George Grodek said this long ago: the distinction between body and mind is only verbal and not essential. Body and mind are one unit. We didn't listen. In this non-dualistic view, it makes absolutely no sense to exclude subjectivity aspects of human functioning, or what we call story, in relation to any physical illness, in either our consideration of causal factors or clinical care or clinical guidelines. I want to give you some brief background to how I got to this. In 1982, I abandoned my academic post in clinical immunology at the Christchurch School of Medicine to retrain in psychiatry, during which my interest in psychotherapy developed. In 1987, I initiated a new multidisciplinary healthcare centre in Christchurch, reignited my clinical immunology practice and integrated it with my newly developed psychotherapy orientation. So, once again, I was treating people referred with all kinds of chronic physical conditions, mostly inflammatory illnesses and diseases, but over time it expanded beyond that. I started listening both as a physician and as a psychotherapist, and I began to see things that had been completely invisible to me in my previous immunology and physicianly roles. So those beige parts out the side were the things I started to look at and see. Let me give you some examples. There was the 70-year-old woman with 5 years of continuous mouth ulcers, on average a dozen at a time, all the time. Totally miserable existence. She was referred for an allergy kind of workup, and I didn't find anything notable, and she didn't have Crohn's disease or Behçet's disease. I asked her what was the most memorable or stressful thing happening in her life 5 years ago, about the time her ulcers began. She had an instant response. My daughter left the Catholic Church. Sitting with her, I started to speculate inside myself what that may have meant to her. And you're already speculating, I suspect. I asked her what was the hardest thing about it. And to my surprise, she said, I can't talk to her about it. I simply encouraged her to talk with her daughter and reviewed her in follow-up 3 weeks later. She had talked to her daughter and the ulcers had gone, and they remained gone. Then there was the 78-year-old woman with a well-attested, or apparently well-attested, when I say apparently, biopsy-proven immunological disorder called mixed connective tissue disease. It's quite a rare disorder. And she was referred to me by a physician colleague for a second opinion after a year of ineffective immune suppressive chemotherapy. And clinically, she suffered from an extraordinary widespread thickening of her skin. Despite her age, her skin could not be pinched. Now, she was 78, and if those of us who are close to that know that our skin can be pinched up like a tent. Some of us more than others. And undressed, she looked like a shiny, firm, leathery barrel. The thickening was so solid around the chest that it was restricting her breathing. I asked the lady when it all began, and somewhat to my irritation, she said, I fell over in the supermarket car park. And after I reluctantly listened to this account about injuries to her face and knees, I asked her how this fall had affected her. She said, and note, I went into my shell. In fact, she used that phrase over the next minute or so 3 times. And she went home, she said, and went into, I quote, the 4 walls of my house, and sat and sat and sat. All her words. And over the next 2 to 3 weeks, the skin thickened. And so the investigations, biopsies, and chemotherapy began. Curiously, 3 to 4 weeks before, whilst waiting to see me, her skin started to improve. I asked her what had happened. The patient kind of knows, you know. She said a friend had visited her and said, come on, you need to come out of your shell. Her symptoms continued to improve, and reviewing her again a year later and confirmed with her managing physician, there was no sign of the mixed connective tissue disease, which is normally a chronic, severe chronic condition. What seemed to have happened was that this elderly woman living alone, who had hitherto through life been fit and well, had been shocked and deeply destabilised by her fall and had retreated behind a safety wall. The skin thickening seemed symbolic of this. And then there was a highly investigated young woman, and there are many, and Anna Louise mentioned one, with long-standing, unexplained, essentially continuous vaginal and rectal bleeding, who had been vaginally and anally raped 15 years before. No one had asked, and she hadn't told to this point. I could fill several days recounting stories of people with physical conditions that appear to rise in relation to life experience, including trauma. And I've provided many examples in my books and other publications. I want to make the point that they include minor and major illnesses. And I need to emphasise that they include both so-called medically explained and medically unexplained illnesses. Symbolic disease or illness, where a physical presentation matches the patient's emotional experience and personal meaning so exactly that it looks as if the body is telling the same story, was a major shock to me. My training was about physical diseases being entirely physical. Yet these symbolic conditions with such vivid stories were often blatantly physical, and the disturbances in the body observable, detectable, or measurable. The problem was the question, how does meaning get represented in symbolically congruent ways in the body? I had no plausible paradigm for what I was seeing, no mechanism, which has been an issue in our conversations today. Now, I'm not at all suggesting that all physical illnesses are symbolic. That's not my point. But these apparently symbolic disorders seriously challenged my normal ways of addressing physical illnesses as separate from the patient's stories and life experiences. They disrupted the tidy perspective that if I have something measurably detectable and mechanistically discernible, I can essentially neglect subjectivity factors as playing a significant role in physical illness. I was both fascinated and nervous. I read of others who had seen similar things. I canvassed a range of literature for insight, including psychoneuroimmunology, body psychotherapies, therapies of emotional expression and embodiment, psychosomatic theory, the nature of experience and personhood, the role of metaphor and the symbolic, the effects of trauma on the body, and much more. And I have referred to much of this in my publications. But let's focus on just one thing for a moment. Consider the development of an infant. It seems obvious that physicality or body and our subjectivity or mind co-emerge together, inseparably from the beginning of life. I mean, does anyone really believe that body starts first and mind somehow gets tacked on at 15 months or whatever? It doesn't make sense to me anyway. We are unitive wholes. Patients with physical disorders are wholes. The disorder emerges in the whole of the physical and the subjective, and it follows that physical disease merits serious consideration of the subjective, the non-physical, the story, particularly the marker experiential events that occur before and around the times illness emerges or relapses. That is what we do in the whole person treatment approach. And so in those early days, I began to work in a whole person way. I saw that people with long-standing chronic physical illnesses tended to improve or even get completely better once we brought the medical condition together with the story. Just connecting the two or giving patients permission to consider the connections helps some people. Working much harder on the story aspects through a mind-body oriented psychotherapist helped others. And whilst we treat all diseases in a whole person way, we've also focused on single disorders such as chronic spontaneous urticaria. In short, I am saying that addressing significant life experience elements may improve, modify or cure the course of a physical illness in many cases. And I can expand on that a bit in relation to urticaria later if you ask. More than that, I believe that treating a physical disease as if it is separate from a person's life as a whole is a fundamental error and negative for patients, particularly those with chronic conditions. Our almost complete cultural commitment to largely technological solutions in chronic illness is both misguided and increasingly unsustainable. And the biggest hurdle to whole person care is not the patient, but rather the institutionalised dualistic assumptions of biomedical clinicians, healthcare systems and evidence frameworks. I disagree strongly, as you can tell, with the state of affairs, and so do the patients. Here is a typical patient quote from our current research of the patient experience of the whole person treatment approach. He, the previous specialist, only wants to know about your hives and the itchiness. He doesn't want to know, would there be any other reason why it has been brought on? See, I shouldn't say that, but it's an impersonal kind of way. So it is good to be able to come in, for someone to take on board what else might be happening in your life, and if somebody could put the two together and then say, well, how about you need antihistamines for a wee while, let's try and get it under control, I guess, but there might be other ways that we can address it. A whole person approach allows for both conventional treatments and the consideration of story. The way the treatment pathway develops depends on each individual patient, the nature of the condition and the pragmatics of the situation. For instance, we do deal with severe immune deficiencies in our department and treat them with effective and very expensive antibody replacement therapies. And we also deal with many other physical chronic disorders such as urticaria, perennial rhinitis, eczema, asthma, idiopathic anaphylaxis, chronic sinusitis, recurrent infections, and a host of other chronic conditions. We typically treat all of these from a whole person perspective. Gathering the story is part of normal care. Turning to practicalities, does being whole person oriented mean that in addition to the normative requirements of a discipline, the clinician must become a skilled psychotherapist, psychologist, social worker, spiritual advisor, or whatever else? This is clearly impossible, and it is where the concept of story assumes importance. The idea of story resonates deeply with our normative human experience, and certainly resonates with patients. Listening for a patient's story whilst doing one's ordinary clinical work is a simple, practical doorway into the world of the whole person, especially that part of the person's world not accessed by the normal biomedical approach to disease. Asking for story might seem a simple matter, but intentionally asking a patient about what actually happened in her life many years ago at age 18 years when her Crohn's disease symptoms started rests on really serious assumptions and working principles. These assumptions are that mind and body co-emerge together and exist as a unit of whole, that the story may be causally relevant, and that responding to the story may have therapeutic potential. Otherwise, why would you do it? This paradigm of whole person care actually mobilises the clinician to imagine the potential presence of story and to ask simple questions of the order that I've demonstrated. But there are other implications. Asking a person to reveal their story material requires courage, because there can be no expert prediction as to what will emerge. It requires self-confidence to enter this zone of uncertainty and to trust that whatever emerges can be responded to adequately and perhaps creatively. And there has to be generosity. The unstated relational dynamic in story gathering is something like this. Of course, you don't say it all. I did say it was unstated. I'm truly interested in you as a person. We all have unique stories. I want to know what happened to you. I will go gently. I won't push you over the edge. Tell me as little or as much as you want. But because we are wholes, illness emerges in a mix of physical and non-physical factors. I am charged with helping you, and so if you are willing, it is important that we consider this together. I hope you will trust me. We are both humans together. You may well experience difficult emotions that are hard to contain. I'm all right with that. I have them too. Thus, getting a story is clearly a rich movement in relationship. Most of the stories implicated in illness, in my experience, are relational stories of trauma, failure, loss, abuse, abandonment, and much more. And these stories emerge within and because of an invitational interaction between clinician and the patient. Whole person care and attending to story is, in our experience, powerful, not least because it liberates into the clinical field currently unaddressed elements of personhood that may or may not contribute to trajectories towards illness or healing. Meantime, and collaterally, the clinician holds on to and exercises any of the useful elements of the biomedical model. Is this all too much? Recently, I sought out a story in a patient with chronic urticaria. He told me that it began when he returned to his work after his summer holiday break, only to discover that his employer had decided, without any warning, that he would now be working in a very different section of the company. Do I really have to wonder and ask about everything in his life? Or can I just start there? Is it possible that the important thing has already floated to the surface? Can I treat this as a doorway? Now, few of us would have any difficulty in imagining that this employment issue could be important to him or to any of us emotionally. So I asked him what he felt about this change. He said, I just accepted it. Really? He had made the connection and he was falling away from it. I imagine inside myself that he might care more than that, but that he might be suppressing some feelings, or that he might not be used to expressing feelings, or that he sees no point because until now his hives have been seen just as a physical condition, or that he felt he could not afford to upset his boss and so on. This kind of imagining is within the scope of ordinary human and clinician experience. But we are now beyond just detecting story. In this case, it's all very well to imagine all these things. Shall I charge in with these wonderings and assumptions in that smart, fix-it way that we have as clinicians? No, I wonder together with him a little. I've imagined he has had some feelings. I meet him in this zone of meaning and feeling. I make some possible tentative connections between the feelings and the illness, and I let it emerge between us. Sometimes it is very simple, and sometimes very complicated. But we don't need to be a psychologist or a psychotherapist to start this process, or to make simple connections. or just to give the patient permission, education and encouragement to consider such connections. The interaction doesn't have to be perfect or prolonged or even all done at once. Whatever emerges, the clinician also trusts in a personal capacity to respond in some kind of way that might be fruitful. It might be to simply say, "I'm really glad you told me this, and I'm wondering how we might address this together." In a wider perspective, story gathering is disciplined and grounded in respect and generosity, and in a relational space in which the therapeutic potential co-emerges between the two, the clinician and the patient. It may be fast or slow, a moment, a session, or a series of sessions. It doesn't follow an algorithm. It may involve one or several clinicians, even a multidisciplinary team. I want now to turn very quickly to the training of clinicians to become whole person oriented. My experience of this includes my own clinical evolution over 30 years, workshops teaching both single and multidisciplinary groups of clinicians over 25 years, supervision of psychotherapists working with physical conditions over 22 years, a university diploma and master's program of a multidisciplinary postgraduate part-time 2-year program over 8 years, and working in the immunology department at Auckland City Hospital, leading, training, supervising clinicians in the whole person approach for immunology patients over the last 10 years. I kind of ran out of breath there. There are 4 main elements that influence clinician capacity for the whole person approach. The first is obvious. The hard mind-body dualism pervading Western culture and clinical practice is a very significant hurdle. Conceptual reorientation is a major and crucial part of training. You cannot do this work as a hard dualist. Secondly, story deafness. Clinicians are so habituated to certain ways of being and listening and asking that training and modelling or retraining and modelling of how to do this is needed. Thirdly, some clinicians are more emotionally capable, empathic and warm than others, so there are different training challenges for each person. And fourthly, each discipline throws up different challenges for training. The diagnostic and reflexive fixed treatment algorithms of doctors make story listening unnatural. Physiotherapists are oriented to touching more than talking, and psychotherapists avoid the body. Those are generalisations. Let me make a few comments about doctors. Anything beyond conventional diagnostic pattern recognition tends to be regarded as noise and shut down. I've watched many doctors in groups, role players and clinics just rolling past or over crucial, rich hints of story. The understandable dread of missing something biomedical will preoccupy and distract the clinician from the person of the patient. There are other issues. There are the appointment and economic structures of practice, medical college power structures and quality control systems, evidence hierarchies privileging group and essentialised data rather than individualised data, normative practice algorithms. All of these and more tend to engender inertia in the clinician, interfere with a relational focus, and oppress imagination. Thus, it is not surprising that the value of being with a suffering person's story, rather than just racing down the usual diagnostic, investigative, and fix-it conduits, is discombobulating for many clinicians. Ironically, many doctors, particularly general practitioners, have quite a knowledge of the story through recurrent contact with their patients, but lack a theoretical base and legitimation to assert any connection with illness. They fear getting offside with patients and indeed with their work colleagues. A teaching session may inspire doctors to go back to their practices excited and intent on listening differently, and by 12 midday on a Monday, Their newfound concepts and goals are foundering. They're seeing story all over the place. They don't have the skills or particularly the habits of response. They feel guilty if they don't respond to every story, and their practice threatens to become incoherent. I could tell different such narratives for every healthcare discipline I've been involved with, and I've listed those already. But people can learn to practice differently, and I list here the things that we have found are needed to train clinicians. Certainly training or retraining in listening skills and towards different content is needed with specific application to each clinician's workplace. Modelling of how to do it is very helpful. The emphasis on each clinician being unique rather than, clones of either myself or other clinicians who are capable in this area. The need for adjunctive help from different disciplines. I'll talk about that in a moment. I've nearly finished, those who might be getting anxious about the time. And support and supervision over a longer period. We now have some 70 trained clinicians, most of them in the Auckland area, though there are 20 of them scattered around New Zealand, who we regard as competent clinicians with a whole person orientation. For the last 9 years in the Auckland Hospital Immunology Department, I have learned that over time, doctors who are resistant and have a powerful investment in biomedicine will gradually absorb the whole person approach at various levels. Our clinicians sniff out stories better now, and these are addressed much earlier, rather than after months or years of deployment of repetitive, wasteful biomedical investigation and re-investigation. They more readily call on someone who can deal with complex stories. The management of the difficult patients, so-called, is enormously improved, but it's not perfect. Clinicians put limits on what they will do. Biomedicine is still the norm. Some of the restraint is because of a clinician's own story issues, but gradually the influence has seeped through the department. At any one time, we have 20 to 30 immunology patients with physical conditions in whole person treatment psychotherapy. Some see private therapists. We have 3 or 4 private therapists that we can refer to, and some see 3 master's level psychotherapy interns on training placement with us from the University Department of Psychotherapy, with whom we have a strong working alliance. And I run a weekly supervision training group for both medical and psychotherapy clinicians together. In conclusion, our experience is configured by my earlier observations of intimate connections between a person's life story and their disease. The coming together of internal medicine and psychotherapy was clearly influential. This has resulted in a focus on non-dualistic wholes, persons, whole persons, stories, meanings, and relationships. Much of our energies have been devoted to addressing how these whole person skills can be generalised without asking all clinicians to become psychotherapists. Thank you.